Grand Rounds, an online series of lectures hosted by Persyst, covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. My name is Katie Colabrese, and I'm a clinical data product manager with Persyst, here to introduce our speaker and topic for today's Persyst Grand Rounds. Through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persyst Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with a broader community to share their expertise and knowledge so that we can all learn and grow together. Each online lecture features an experienced epileptologist or neurophysiologist presenting on a topic of their choice as it relates to EEG monitoring and analysis. Please visit www.persyst.com/grandrounds to keep up to date. The schedule is subject to change. Conflicts of interest. The opinions and viewpoints of each speaker are solely their own and do not represent Persyst or any other commercial entity or commercial interest. Speakers are not required to include Persyst, its software, products, or services. The content presented was not prepared or edited by Persyst. Persyst is not providing any form of compensation. There will be time for questions after the talk, but please write your questions in the Q&A area. There is a button at the bottom of your screen. A recording of this webinar will be made available to all participants afterwards. We welcome as our speaker today, Dr. Lawrence Hirsch, Professor of Neurology at the Yale School of Medicine, Director of the Neurophysiology Fellowship Program, Division Chief of Epilepsy and EEG, Co-Director of the Yale Comprehensive Epilepsy Center, and Co-Director of Yale's Critical Care EEG Monitoring Program. Today, Dr. Hirsch will speak on the clinical uses of quantitative EEG other than seizure detection. The learning objectives are to recognize the patterns of ischemia using quantitative EEG, appreciate the ability of quantitative EEG as a general brain monitor in critically ill patients, and understand the limitations of quantitative EEG. Dr. Hirsch completed medical school and internship at Yale University, neurology residency at Columbia University, and a 2-year fellowship in epilepsy and EEG at Columbia. He remained at Columbia on the faculty from 1997 to 2011, where he created and directed the continuous EEG monitoring program at New York Presbyterian Hospital, Columbia University Medical Center for 10 years, and became professor of clinical neurology at Columbia University in 2010. He moved to Yale University in 2011 as professor of neurology, director of epilepsy EEG, co-director of critical care EEG monitoring, and co-director with Dr. Dennis Spencer of the Yale Comprehensive Epilepsy Center. Dr. Hirsch has published more than 150 original research manuscripts and more than 100 invited reviews, editorials, or chapters. His research interests and publications are on topics such as brain monitoring with EEG in the critically ill, status epilepticus, brain stimulation for epilepsy, epilepsy surgery, seizure semiology, electrocorticography, brain mapping, effectiveness and tolerability of anti-epileptic drugs, seizure clusters, and sudden death in epilepsy, or SUDEP. Dr. Hirsch has directed symposia and lectured at many national and international epilepsy and neurology meetings. He's the founder and former chair of the Critical Care EEG Monitoring Research Consortium, which now includes over 50 centers. He has won multiple teaching awards and is co-author of the first ever Atlas of EEG in Critical Care. Please join me in welcoming Dr. Lawrence Hirsch.
Thank you very much, Katie. All right, let's get started. So I have a whole bunch of things to cover. As the title mentions, I will not really be talking about seizure detection, which of course is the most common use of the quantitative EEG and continuous EEG monitoring. But we're going to talk about everything else that quantitative EEG can do for you clinically. These are my disclosures. As Katie mentioned, I do have an Atlas of EEG in Critical Care, and the new edition is available now, this 2023 edition. And you will see many examples from that in this presentation. I do have a few slides that were provided by Persyst years ago that I put in part of the talk. And I stole slides from many of my colleagues. These are all unrelated disclosures. Okay, so the first topic I'm going to talk about is detecting ischemia with EEG, which has been most done in the subarachnoid hemorrhage patients. So why does it work so well? Well, we know the cortical layers 3 and 5 are particularly sensitive to ischemia, and they're the ones that generate most of the EEG signal. And it turns out that EEG can pick up neuronal dysfunction while it's still at a reversible stage. So you get a window of opportunity to intervene. So EEG changes start to happen when your cerebral blood flow gets below 25 or 30. You still have some synaptic transmission and reversibility until you get much lower than that, below somewhere around 17 or 18. And then cell death occurs when you get below 10. And the EEG changes you see have been known really for more than a half a century, but you get slowing with ischemia and loss of fast activity. And when it's really severe, basically the EEG goes flat, which was actually given this name at one point of RAWAD, regional attenuation without delta. But that basically means your EEG goes flat. And that's usually at an irreversible stage. So this is a nice summary of that from Brandon Foreman and Jan Claassen years ago. So as the cerebral blood flow drops, this is what your EEG looks like. So you start to lose some of your faster frequencies. Then you get some theta slowing, eventually you get delta slowing, and then you get suppression. And this is what's happening at the cellular level. And the important thing really is all at this time, you have first subtle and then really obvious EEG changes, but you're still in the reversible stage. So that's why it works so well, particularly in patients with borderline perfusion where you have an even longer reversible stage. So this is a graph of the typical power. The solid line is kind of a relatively normal EEG. Everybody has more power in the slower frequencies, just because they tend to be higher amplitude. But then what happens when somebody gets ischemic, you turn into this dotted line. So delta activity goes up, alpha and faster frequencies all go down, and it switches somewhere around 6 hertz, maybe 5 or 6 hertz. So things slower than that go up, things faster than that go down, and that's the basis of almost every ratio used to detect ischemia. Okay, so we use basically the fast to slow ratio of some kind because they go in opposite directions, so that ratio magnifies the change. So DCI, or delayed cerebral ischemia, occurs in a large portion of subarachnoid hemorrhage patients. Some of the oldest literature on this, the first one that used quantitative EEG was from Paul Vespa, and showed that quantitative EEG could detect every angiogram-defined vasospasm. It was 19 out of 19 patients, and that the changes on the quantitative EEG came before transcranial Doppler or angiogram detection by at least 2 days in 10 out of 14 patients. And this was back in 1997. And the measure they used was the relative alpha variability. So relative alpha is the alpha power over total power. And then the way they did this was you just look at a graph of it and you rated how variable it was on a 1 to 4 scale. Later, this study from Columbia with Jan Claassen that I was involved with took poor grade subarachnoid hemorrhage and with a 7-day protocol and looked at all different types of quantitative EEG measures to see which was the best for picking up ischemia. And in this study, it was the alpha delta ratio that was the best, but specifically it was one where you accounted for state. So that it was the post-stimulation alpha delta ratio. So you made sure they were in their maximally awake state. And that's an important point. There are sometimes pretty dramatic differences between the more awake and less awake states in all kinds of patients in the ICU. And you really want to compare the same state. And the only way to do that is to stimulate them first. And then there were specific cutoffs given patients with an alpha delta ratio dropping by more than 10% for 6 consecutive recordings. These were just short snippets where it was calculated. And that was a highly sensitive measure if you had 6 in a row, or a single recording that dropped by 50% from baseline. So a much bigger drop at only once. And that had reasonable sensitivity and specificity. So here's an example of tracings of alpha delta ratios in the different distributions, vascular distributions. And you can see here in the right anterior circulation, this is day 6, there is a gradual drop in the alpha delta ratio. So that happened here. Eventually there was a transcranial Doppler change. There was no clinical change until these red lines. The patient actually went to angiogram, had some treatment that seemed to work, brought the alpha delta ratios back up, but by the time they got back to the neuro ICU, it was way down again, and they went on to have a big infarction. So this just shows that you do get a window before any of the other measures by doing continuous EEG monitoring. This was the raw EEG at before that happens, and then a day later in the DCI period, you see much more slowing, actually on both sides, but more on the right. And these are the CAT scans at day 2, 7, and 8. You can see pretty extensive infarcts actually on both sides. So other people have tried to figure out what the best measure is in more recent studies. This one was in 20 subarachnoid hemorrhage where half had DCI. They found the alpha delta ratio was the best single measure, but when you combined it with alpha variability, you actually did even better. And they also found that quantitative EEG changes came before clinical by a mean of 7 hours and way before CT scan changes. This is from that paper showing all the different quantitative EEG features and the percent change, and it compared the DCI group is the darker one, and the ones without DCI are in white. So the alpha delta ratio had the best separation, but you can see several of the others were good too. This the one right next to it is alpha plus beta to delta ratio, or to a delta theta ratio. But it's the fast to slow ratios all did reasonably well. This is alpha variability, so there still was a difference, but not nearly as much separation. Another group in 2020 did a systematic review of all the measures for detection of DCI with EEG. And their conclusion was DCI can be picked up 7 hours to 2 days before diagnosis by any other means. And that alpha delta ratio was the most established measure, followed by alpha variability. And then here's some data on the seizures as well in those. Okay, and then most recently, this paper came out in Annals of Neurology. I guess it's not that recent anymore, but it's the one I find to be the clinically most useful, and we pretty much go by the method used in this paper for detecting DCI. So this was a large study, 100 consecutive patients with high-grade subarachnoid hemorrhage, and they looked at 4 features, and you had to have a clear and persistent worsening or new emergence of one of these 4 things. So it was focal slowing, new or worsening epileptiform findings, decreasing alpha delta ratio, and they use these general guidelines, the same numbers I gave you from the prior papers, but it was all done just visually, not quantitatively. It was just by looking at the tracings. And decreasing relative alpha variability, again, just by grading on a 1 to 4 scale in the different regions on each side. So this was all done just by looking at the quantitative EEG tracings twice daily. And then they had someone blindly deciding whether it was DCI or not. So their protocol was to do continuous EEG for 10 days. It ended up with a mean of 7.7 days. In the patients who developed delayed cerebral ischemia, at least one of those 4 EEG alarms occurred in 96%. That's very good sensitivity. In those without DCI, there was at least one alarm in 20%. So there were some false positives, but not that many. The other way to look at it is with the flow chart here. They had 60 patients who tested positive, meaning one of these EEG alarms occurred. 50 out of 60 were true positives and 10 were not. And of all the ones that came out negative, 41 out of 43 were accurate. So there were 2 false negative cases. So this is a table of all the patients with DCI compared to the ones without. Again, showing any EEG alarm, 96% versus 20%, highly significant. And then all the specific features. And what was most interesting from this study was that the best separation was actually in new epileptiform abnormalities. So you can see 63% versus 8% for an odds ratio of 20. So that was kind of a surprise from this paper, that was better than the alpha delta ratio and other measures. Now you see at the bottom the transcranial Doppler numbers. So there was separation. It did reach significance with 2 of those measures, but not nearly as much of separation and much lower odds ratios than some of the EEG features. And if you look at any EEG alarm, it was an odds ratio of 102 that you have DCI versus no DCI. So overall, this is the sensitivity and specificity, positive predictive value of 83%. And this shows the latency from the EEG alarm to DCI, and it's in days. So you see many of them, you get quite a window. There was a median of 1.9 days of a warning, and it exceeded 12 hours in 82% of cases. And they concluded the number of patients you need to monitor to detect a case of DCI that you otherwise would not detect was between 3 and 7. So this is how we report it, largely based on that. So each day we use the different middle, anterior, and posterior cerebral artery distributions on the left and right. And we looked at those 4 things: epileptiform patterns, alpha delta ratio, focal slowing. And rather than relative alpha variability, we actually use the same alpha to delta ratio variability. So we don't need yet another trend to follow. So we look at variability of ADR, similar but not identical to what was done with other papers. Again, this is just a 1 to 4 rating. For the alpha delta ratio, we put a range, and our guideline is it should be the range in which 50% of the values fall. Again, we don't do this quantitatively, just eyeball the tracing. You can zoom in if you need to figure out those numbers. And then each day we update it, and we put in red anything that is of significant worsening from the prior day. So you see here, on day 3, the left middle cerebral artery territory, the alpha delta ratio dropped, and there was focal slowing there. And we have a column for comments too. And this is the setup we use for doing this. So this is a 24-hour trend. We usually have a 0 to 2 scale. If it's way down low, you can change it to 0, 1, but just keep it the same when you're comparing day to day. And so these top 3 are the alpha delta ratios in the middle cerebral, anterior cerebral, and posterior territories. Then we use asymmetry spectrograms. So if it's blue, that means there's more power on the left. Red means there's more power on the right. And it goes from 0 to 20 hertz for each one of those. Again, the 3 territories. And then at the bottom here, we have amplitude integrated EEG. And that's actually important because sometimes EEG just goes flat. Your ratios will be pretty much useless or unpredictable when that happens. But your amplitude integrate will plummet down to the bottom. So it's important to have some measure of either total power or amplitude. So we use amplitude integrated EEG for that. So it's significant asymmetry whenever one of these lines is above the other. It doesn't have to be by a lot, as long as it's consistently above, then that's an asymmetry. So here you see really a marked asymmetry, particularly in the anterior cerebral territory, where the alpha delta ratio is too low on the left. And that can be from different things, right? It can be from more slowing on the left. It can be from attenuation or less fast activity on that side, or it can be from both. And that's where the spectrogram helps you. So here's that spectrogram. that corresponds to that. And you can see faster frequencies, so the top half of this, are all much more on the right. So that means they're attenuated on the left. Whereas at the bottom and lower frequencies, there's really not much asymmetry. Maybe a little more slowing on the left, but it's pretty pale blue, so that's not very significant. So here it's mostly attenuation on the left that's driving that difference. So that's the kind of tracing we use, and the variability we just judge by how bumpy this is, so it's actually pretty good over here. So this case, I just wanted to point out that you can set alarms on these things. For example, this is the suppression percent, and we have it set here to go off if it goes above 20%. So this is, I don't know, about 6 hours of EEG, and it shows over time you start to get a little bit of suppression and then some bursts of more, and by the end here there's a whole bunch of suppression, and it goes way over 20% and it passes that alarm threshold. The bottom half is actually using a miniature depth electrode. So this was one of the patients who had invasive monitoring. And you could see we run on that a regular spectrogram or CSA. This is a total power measure. This is amplitude integrated EEG, and this is the suppression percent. So you can see this, eventually there's an obvious change on scalp, but not till the end of this 6-hour segment. Whereas on the depth, you see dramatic changes much earlier. Power was dropping way in the beginning of here, including hitting the alarm threshold here. And the suppression went up much earlier. So these depth electrode just gives you a much better signal to noise ratio, and you can pick up these things much earlier with an intracranial recording. So these are the raw EEGs corresponding to that. So this was in the beginning. I'll show you where they're from. So this is A, B, and then I'm going to show you D. So A was here. The bottom is this is the depth electrode in these boxes. Showed lots of epileptiform discharges. And then here you see it basically went to burst suppression in the depth. The scalp is also getting somewhat attenuated. And here's the burst suppression part. So when you're in burst suppression on your amplitude integrated EEG, you get a very broad tracing because there's both very low amplitude and high amplitude in every 10-second period, and that's how it's calculated. So you see this very thick band, you know you're in burst suppression. And eventually it gets mostly just low amplitude or mostly suppression. And that's at the end here. This is another case that had a depth electrode, and that's done as part of what people call the bundle, where you do intracranial pressure, microdialysis, you can have the Lycox tissue oxygen or cerebral blood flow measures, a bunch of different things you can measure. So this was a patient with a large right MCA infarct who had this miniature depth. It's just a small depth, but right through the cortex. And that's at the top in this green box, and the rest is the scalp EEG. This patient was being treated with temperature management and was hypothermic and having some micro shivering. So you see nothing but a muscle artifact on the scalp. And then, so this is at 9:45 p.m. You start to get discontinuous in the depth. The scalp just shows muscle, no obvious change. Then you start to get flat in the depth. Not quite flat, but much more attenuated than it had been. Again, the scalp just showing muscle. Then you get periodic delta waves in the depth. And then it starts to recover and you get some more continuous activity again. So you see the scalp really showed no hint of any of that. So that all happened back here where suppression burst first appeared. And this is overnight data on all the multimodality measures. So you see there was a brief burst of intracranial pressure at the time that happened, up to 30, but then went back down basically to normal and stayed there. The tissue oxygen did plummet, but it took several hours to get to really worrisome levels. But certainly by this data point, you'd see it's plummeting down and know something was wrong, but it was way after the EEG change. And the lactate pyruvate ratio was actually super high the whole time, but not really helpful. So this patient had a big hemorrhagic transformation of their infarct, and that's when that happened. So the depth electrode picked it up. The scalp EEG didn't pick up at all. These other measures showed a hint of it, and the oxygen did show up at much later. Another thing I want to point out is the latest version of Persyst lets you do a comparison to baseline, a statistical comparison. So you can pick a baseline EEG and say, call this the baseline, and then have it run a statistical comparison to that, and not only over one record, but over days. And so that's the whole idea is for subarachnoid hemorrhage. So this is actually a patient who had a carotid clamping for endarterectomy. And you can see a sudden change on the left side here, or the sudden attenuation. So here's an example of that. This is what it's called versus baseline. And it shows a Z-score. It's basically standard deviations from your baseline. And this marks where you established your baseline, this little pink bar. So that was the baseline. This is showing that suddenly there's 6 standard deviations down in the power in almost all frequencies. So here's the EEG at baseline at this point. And now right in the middle of that change, it looks like this. So very attenuated on the left. And then later it starts to recover. And that's at this point near the end of that process. So you can also see that there was an increase, statistical increase in slow activities at the time there as well. So conclusions on ischemia detection. So EEG is very well suited for detecting ischemia as long as it involves a large area of the cortex. It does so at a reversible stage. You get decrease in faster frequencies, or 6 hertz and faster, and you get an increase in slower frequencies below 5 hertz. The alpha delta ratio helps accentuate that. It's even easier to pick these things up with intracranial EEG. And this type of monitoring, even though it's been well proven over and over and seems to be better than any other measure, is still highly underutilized. And it does take some effort and some expertise in interpreting it, mostly to make sure you're not looking at artifact. But the software removing the artifact is very helpful for that. And as long as you're looking at the raw EEG to confirm these changes, that also helps as well. And you can use these alarms to help you. They can either just put a mark in the record, or you can have them send you an email message. All right, so jumping away from ischemia, what are some other uses? So I just have a kind of a potpourri of interesting things you can see. So this is a patient who got right here a bolus of a barbiturate. So you see suddenly all the power goes into the delta frequencies. But the main point of this one, this is actually 12 hours. And what you can see then is that there's a gradual wearing off over the next couple hours after that bolus. I think I have a zoom in of that. Yeah. So you see it's gradually wearing off. So this is something it's hard to see if you're just looking page by page at the EEG. But you can see faster frequencies are coming back and the delta is dropping. So this is someone you got to keep a close eye on, because their pentobarb is starting to wear off. So in the next several hours, don't be surprised if the effect goes away. I said I wouldn't show you seizures, but this is just to show you what really long-term trends you can see. So this was actually a patient in non-convulsive status to the left, and very gradually resolved over 11 hours. And I use this to show the concept of the ictal interictal continuum, as it's a super gradual process from ictal to non-ictal. And it doesn't make any sense to pick a point where they went from seizing to not seizing. So this is just what the raw EEGs look like. Clearly not seizing at all by the end. But it just shows by looking at many hours on one page, you can see very clear gradual changes. But again, page by page, it can be very hard to pick up. So this is a case. So just looking at the CSA with hemispheric averages shows you a few things. So one is you see much more delta on the left. So it's obviously slower on the left. You also see this band in the, it's probably all beta or alpha and beta. That's much more on the right. So there's obviously something wrong with this hemisphere. On the left, it's got more delta and less fast activity. However, then there's a sudden change here where you get much more fast on both sides, and then you get more slowing, more delta on the healthier side until they really look pretty symmetric after. So you think, what gives you more delta and more fast activity? The answer, I'll show you the raw EEGs first. So tons of delta on one side, more fast activity on the right. And then something happened and you see tons of fast everywhere, but even more so on the healthier hemisphere. But the overall EEG is slower than it was, including on the healthier side. So this is from a midazolam bolus. So it's drug-induced beta, plus you get slower activity from that. All right, this is something Dr. Fong and I like to call the humpback whale sign. You get this shape that looks very much like a whale to me. So this was someone, so at baseline here, the top is suppression percent, and these are the CSAs. You see just tons of artifact, right? Things that look like they're coming down from the top maximal at the fastest frequency are usually muscle artifact, which it was. And then there's a something happens that gets rid of all the muscle completely. And you see it's actually a very attenuated EEG with maybe just some bursts of low power. And then eventually it gradually wears off until that muscle activity comes back. So it's really the only change here is muscle. And in this case, this was from a paralytic being given. You'll get the exact same shape like this without this muscle problem just when you give a bolus of a sedative. You see a sudden increase in suppression. Usually it's a barbiturate or propofol. And then you'll see it last for a while and then slowly wean off. So you get this characteristic shape. But in this case, it was all muscle from a paralytic. So this was the EEG at the very start. Here it is after the paralytic was given. It's really mostly suppression with some bursts. And then this is it as it's starting to wear off. The muscle's coming back. And then it's muscles completely back as the paralytic wore off. All right, this is a patient who had cancer, sepsis, was super ill, and was DNR status. So this is amplitude integrated EEG, suppression percent, and the compressed spectral array. I put in the numbers here as a reminder of how it works. So amplitude integrated EEG is a linear scale from 1 to 10, and they give you the lines of 1, 2, 3, 4, and 5 microvolts, and then it jumps to 10. And then above 10, it's a logarithmic scale from 10 to 100, and the lines are at 25, 50, and 100. So this is someone who was pretty low voltage to start. Everything was below this 10 microvolt line, but then gradually gets lower and lower. And then this suppression percent, there's already some suppression at baseline, more so on the right. And then that gradually went up to 100% suppressed. And then here's one, the spectrogram also shows you some asymmetry. There's more power on the left than the right. And then all the power gradually goes away. So this was actually somebody near the time of death, and their brain gradually just went flatter and flatter. Here's the EEG in the beginning. There it is getting much more attenuated, and then it's completely flat by the end. So these are the kind of changes you see over many hours. This one is showing you again how you can use alarms. This was somebody being kept in a penobarb coma for raised intracranial pressure. And basically showing, so this is all scalp. Well, this is a rhythmicity measure, which I haven't really talked about. It's mostly used for seizure and periodic discharge detection. Here's the spectrogram. You see it's very low power and suddenly a burst of more power. Also, the other point is when you see this burst, it actually goes up to very high frequencies. So that usually means either you really have beta in there, or whatever pattern it is has some sharp components, because whenever it's sharp or spiky, it takes very fast frequencies to make something really sharp. So if you, even if you have like 1 Hertz periodic discharges, if they're spiky, you will get some faster components, some power in the faster frequencies in the CSA. You see here the suppression percent. You notice I say percent, even though it's labeled ratio, because that's actually what it is the percent of the record that is suppressed. So suppression percent is a more accurate term for me. So that you see here dropped. In this case, the alarm was set for when the suppression got too low, because that meant they were coming out of their induced coma. So it did eventually reach this alarm point. This person happened to have a depth electrode also, and just shows the same thing much more clearly, but it was quite clear on the scalp in this one, so you didn't need it. So this was the EEG in the beginning, completely suppressed. This was it at the time point where the alarm went off, so you started to lose your suppression. And you see there are sharp components in there. This is part of why that faster frequency showed up. This is something we recognized when we started doing quantitative EEG, that you get these very regular cyclic patterns, and you can see it on almost every kind of tracing. And this is, these alternating backgrounds in encephalopathic patients are called CAPE, stands for cyclic alternating pattern of encephalopathy. So this is only 1 hour of EEG shown on the page. So this cycling is happening about every 50 seconds. It just changes patterns. So here's the pattern at point A. So this is actually the more alert or the stimulated pattern. In fact, here the patient got stimulated and they basically stay in that pattern. But if you leave them alone, they'll cycle between that and this other pattern. This is actually their sleep pattern, even though it's faster and looks healthier. And that's very common in the critically ill patients, where when you stimulate them, they get higher amplitude, slower, and get more sharp waves and epileptiform patterns. So that's known as CAPE, the cyclic alternating pattern of encephalopathy. Sometimes this pattern will have periodic discharges or even seizures in it, and it keeps alternating. So that's still a form of CAPE. And it probably is to some degree a healthy sign, because it's normal to have a cyclic alternating pattern in sleep. Then it's just called CAP, C-A-P. And this is just seems to be either just the normal CAP or an accentuated version of it, where their more alert state is abnormal. Sometimes epileptiform, sometimes not. So this just shows CAPE. They eventually wake up and they're in the more continuous, more awake pattern. This is just a reminder of the amount of time you put on a page. So if you try and look at a 24-hour trend that's shown here, and they have one seizure that lasts 30 seconds or a minute, it's going to be really hard to find. It's actually there. There's a seizure detection with the seizure probability, but it's super hard to find. But if you zoom into a 1 hour trend, exact same EEG, just zoomed into the beginning of it, it becomes very clear. Seizure, we're bumping the amplitude. It's clearly maximum on the left, all the powers on the left in the spectrogram. See it on the CSA, you see it on the rhythmicity, including now you've zoomed in enough to see this diagonal pattern. That's really the sign of evolution in frequency, which means it's a seizure. It's going from faster to slower. And you see it in the seizure probability, seizure detector as well. This is the opposite. So this is using a 1 hour trend. You see there's no hint of any trend or pattern over time. Right? It's more attenuated on the right, which is why the asymmetry is showing all the power is blue. It's more on the left. You see the amplitude integrated showing red on the bottom. That's the right side. Blue is sticking up. So blue is higher amplitude. The pink little band in the middle is when they overlap. So there's very little overlap here. So the right hemisphere is much lower voltage than the left. So that's we're using a 1 hour trend. But if you use a 24-hour trend in this case, you can see there was a long gradual change here, and much more power is happening on the left, and it was explained by the amplitude on the right dropping. So you see pink, they're all overlapped. It's nice and symmetric here. As time goes on, the right side of the red starts to drop in amplitude, and you can see the blue actually stayed the same, but it's now above the right hemisphere. So this was a long gradual attenuation in the right hemisphere. Very hard to see page by page or even with a 1 hour trend, but with a 24-hour trend, it's obvious. And this is just a reminder that there's this artifact removal is super helpful, and it allows your trends to continue without being ruined by a bad channel. So here's a bad channel. It's shown here. You see when the artifact reduction is on, that's just blanked out, and your trends continue to work fine. It just drops out that channel, or the 2 channels using that 1 electrode. This is the display we use at the bedside. So we keep the video. We have live raw EEG running, so this will be moving. And then we use usually a 4-hour trend. We have the seizure detector there. We have some rhythmicity, CSA, the asymmetry spectrogram, and amplitude integrated EEG. So that's what we leave at the bedside, and for our monitor watchers to look at. This is what we use just for screening. This is just a couple more interesting cases. This is a 76-year-old who was having a bunch of little seizures. And then that's what one of them looked like. And then here you can see this asymmetry, right? There's attenuation on the right side. But you can see the healthier side starts to lose that faster stuff, at least the theta, maybe the mid-range things, over time. And the seizures went away. And I remember this case. Oh, I gave it away with the title there. I called and asked, how'd you get rid of the seizures? Because we were trying not to intubate this patient, and we had tried several drugs, and they were still having some non-convulsive seizures. And they said they hadn't done anything. This is what the raw EEG looked like. Started, you can see a clear asymmetry. So the left has more of this theta frequencies. The right is more attenuated. And then at this point, the left caught up, started to get attenuated as well. And it turned out this was CO2 retention. The patient was acidotic, and that's what made the seizure stop. And the patient was really lethargic. So they eventually intubated the patient. Oh, let me go back. Somewhere around here, they intubated the patient. The background recovered, but several hours later, little seizures showed up that we didn't notice. And the patient went into non-convulsive status. It was eventually noticed, and midazolam was started. That's after the midazolam. So in one page of EEG, this is I think 8 to 12 hours of EEG. You can see the seizures, some acidosis with the background on the healthier side getting worse, intubation, recovery of the background, little seizures popping up, status, and then suppression from midazolam. So the suppression percent, I kind of talked about this already, but this is how it works. It's a sliding 10-second window, and it counts the percent of the time where it's flat for at least half a second. And you can set that it's usually a 5 or 3 microvolt cutoff. We use the 5 microvolts. So if it's below 5 microvolts for at least a half a second, then that will count as time in suppression. So it's just the amount of time in that 10-second epoch that is below your cutoff. So here's just to get used to. This is very compressed. So each of these faint green lines is a second. You can see a whole bunch of seconds in a row that are completely flat, then some activity. So this is about 60% suppression. And if you put the cursor, it gives you the actual number at that particular spot. And burst suppression, you get this very thick tracing on amplitude integrated, which I mentioned. Suppression percent is shown there. This is obviously more suppressed. So this is what 85% looks like. And you start to see it's mostly at the bottom with just some bursts. So there's now some 10-second epochs that are completely flat. And then this is getting closer to 100%. So that was 95% suppressed. So that's just a little bit about the suppression percent tracing. So it turns out EEG is pretty good at picking up raised intracranial pressure as well. So this was a paper Zubaydah Sheikh wrote, I was part of. So there were 7 cases with episodic increased intracranial pressure. So 2 of them had transient unresponsiveness, presumably from plateau waves, and their EEG showed generalized rhythmic delta and attenuation with about a 30-minute warning on the EEG before any clinical change. There were 2 patients who had just diffuse slowing and attenuation up to 24 hours before clinical change. 2 patients who had intraventricular hemorrhage had cyclic patterns. One of them was once per minute, one was 6 per minute, which might correspond to these Lundberg B and C pressure waves. And 4 of the 7 had prominent EEG changes that were between 30 minutes and 24 hours before any clinical change. So basically, again, it's just a window where you can detect raised intracranial pressure before it's picked up clinically. Here's just a couple of those cases. So this was an 11-year-old, had a Chiari decompression, but when the patient sat up, would eventually become unresponsive. And this is what the EEG did. See just diffuse slowing, eventually generalized rhythmic delta. This really looks like a could be a syncope case, and eventually goes flat with lots of muscle artifact as he basically loses consciousness. This was a patient with leptomeningeal carcinomatosis with hydrocephalus, getting intrathecal chemotherapy, and had spells of unresponsiveness. This is the patient's baseline EEG in the past. This is the baseline EEG, this admission. This is 30 minutes before the event. So you can see there's obvious slowing compared to that baseline. And this is actually during the event. And this is just acute raised intracranial pressure. This is a patient who had a malignant right middle cerebral infarct and went on to herniate. And this is the raw EEG progression. But this shows a 30-hour trend that starts 24 hours before herniation. So the herniation was near the end of this. It just shows this long gradual changes that are easy to pick up on quantitative, particularly the suppression percent started going up many hours before any clinical change, and the amplitude integrated started dropping. You can see some of it on the CSA, you start to lose power as well. So again, you just, you'll sometimes get a very long warning before anything is picked up clinically. This was another case of hydrocephalus being picked up. So this is 4 hours of quantitative EEG on the page. This is it's all scalp. This is amplitude integrated here. So you see a big drop in that. This is the suppression percent. Eventually, that goes up significantly, but several hours after that amplitude started to drop. This is actually total power in the left and right with an alarm set on that. And this was a patient with cryptococcal meningitis and a lumbar drain. And this happened to occur in the late afternoon while we were doing our afternoon round. So we noticed it suddenly started to become more attenuated and called in. It turned out the lumbar drain had stopped working and they hadn't realized it yet. So they checked it, it hadn't drained in a few hours. I'll show you some raw EEG. So that was their baseline. It's highly abnormal. This was at the beginning of that attenuation, and then later here it became very attenuated. This is now a 16-hour view of the same thing. So all that happened in the left third of this. They fixed the drain and it gradually recovered back to the baseline. So that was one where the EEG detected a lumbar drain failure. This is a nice paper in 13 kids looking at detection of elevated intracranial pressure. So they found there was a rise in the suppression percent, a median of 3 hours before recognition on exam or imaging, and considered that their therapeutic time window. And they initiated a protocol of doing 2 to 3 days of continuous EEG for any children at risk of elevated intracranial pressure. And here's one example. There happened to be a seizure, but that wasn't the point of this one. It just showed a rise in the suppression percent, and before the clinical change was way over here. So it gave you several give you significant warning before any clinical change. So this is the last one I'll show, and we'll take some questions, have some discussion. So this shows a very regular cyclic pattern. So what can you tell from this? Well, number one, it's got some rhythmicity, particularly on the left side. So that could be rhythmic or periodic. They both count for this type of measure. It's mostly lower frequencies. Cycling, again, more power on the left. You see it's mostly on the blue in the asymmetry spectrogram. The amplitude drops way down briefly each time and then jumps up. And you can tell it's a pretty low powered study because the suppression is going up and down as well. So the times of suppression. So what could give you this? This is clearly a CAPE pattern, right? It's a cyclic alternating pattern. The other thing you can see is during these bursts, you get some very high frequencies. Could be muscle, but probably not, or it'd be more prominent at the top. So that tells me there's very likely going to be some sharp components in there, because most of it is low power. So if you have something like 1 or 2 hertz periodic discharges that are spiky, will look just like this. So this is actually, again, it's CAPE. This is the less awake, unstimulated pattern. And then it alternates with this pattern. That this is their awake pattern of lateralized periodic discharges that are fairly sharp. So this is basically cyclic lateralized periodic discharges. If you stimulate this patient, they'll stay in the LPD pattern. So with that, I will declare all of you literate for reading quantitative EEG, and I'm happy to take questions. Let me stop sharing.
Few questions coming in, and please type your questions into the question and answer area. There's a button at the bottom of the Zoom screen, and I will pass them along to Dr. Hirsch. So the first question we have is about your preferences for monitoring with subarachnoid hemorrhage. I know earlier in your talk you mentioned a little bit about the versus baseline trend, but do you have any more general recommendations or other trends that you like to view along with that one?
Yeah, so I showed when we use our basic comprehensive panel looking for general trends and seizures like we do in all our patients. But then we have that other window that I showed of the alpha delta ratios. So we have alpha delta ratio in the 3 territories. And then we do amplitude integrated EEG in the 3 territories and an asymmetry spectrogram in each of them. So it's basically 3 different panels looking for that. So the amplitude, the symmetry, and the alpha delta ratios. And we usually will just look at that in a 24-hour window.
Great, thank you. Okay, so we have a few more rolling in here. When do you think it is useful to have a depth electrode in quantitative EEG?
Well, it's almost always useful to have it from an EEGer standpoint, but so we pretty much only put it in when patients are getting invasive monitoring for other reasons. So we use it for our severe traumatic brain injury patients and some of our high-grade subarachnoid hemorrhage patients. Some other places are starting to do it in post-cardiac arrest or post-anoxia as well. So I think there's some other questions about them. So they're placed bedside, and they're very superficial. So it's just really just through the cortical mantle. So it's just barely reaching the white matter. You want to make sure you span the cortex. So you get 2 or 3 contacts in the cortex. And it's been a very good way of monitoring the brain for ischemia, for seizures, for any major changes as well. So I showed one of that hemorrhage into an infarct. And then you see a lot of seizures on there too. I didn't talk about that, but a lot of times you'll see seizures on that depth that you won't necessarily see on the scalp. It's very hard to know what to do with those, but that's where we use the other modalities to figure that out. If there's an associated increase in lactate pyruvate ratio or a drop in tissue oxygen, then those are signs that it's actually causing neuronal stress or injury, and we will treat those. But if nothing's changing in those other measures, you probably do not need to treat those. But it's interesting. We'll learn a lot more from those as more patients start to do that regularly.
Okay, the next question, for delayed cerebral ischemia, most of the studies seem to be regarding subarachnoid hemorrhage. Does EEG have similar utility in detecting salvageable tissue in ischemic stroke?
Yes, there's pretty significant literature in the just stroke and vascular world as well, but not as much, mostly because with the subarachnoids you get such very slow development of ischemia. So that's why decades ago we were able to get that in subarachnoids and not the others. And then decades ago, of course, there was no treatment for the typical strokes anyway. So people were less interested in monitoring them. But now that we have so many great treatments for acute stroke, there's much more interest in that. So yes, it can definitely be used in people who are at very high risk of having additional ischemia, like people with a high-grade stenosis that hasn't been fixed yet. People after some interventional procedures where you think they're at risk of having additional ischemia. I think those are great patients to monitor.
And we have a few different questions about alarms, and just practically what time intervals you like to use for bedside monitoring to be useful for different conditions so that you make sure you're capturing a lot of these different conditions over time.
I'm not sure if they're referring to alarms. So for ischemia alarms, I usually will make sure it's lasted for 5 or 10 minutes before I have an alarm. Because if something happens for a minute and goes away, that's unlikely to be a significant ischemia episode that I need to worry about. But it depends what you're looking for. Obviously, if you're looking for seizures, you don't want a 10-minute window. Then you can use the seizure detector. But usually we're looking for major persistent changes that last more than 10 minutes or so. So that's what we'll use as the minimum duration for the alarms.
So for example, like an alpha delta ratio and a subarachnoid hemorrhage, something like that.
Right. And the alpha delta tracing itself is also somewhat smoothed. It's so you won't see if there's a little blip of artifact, you won't see a huge change. It's averaged over a period.
So for a lot of these examples you showed over 24 hours or 30 hours, and you have these panels set up at bedside. Is there a particular interval that you have in your workflow for referencing these panels? I know you mentioned you like to use the comprehensive panel during live monitoring. Is there a different time interval that you set for that?
Yeah, so for the live monitoring, we actually use we call it bedside display, but I think that might just be us. So it's not quite the whole comprehensive thing. We get rid of a bunch. It's about half of them. And we use at the bedside, we use a 4-hour window. For people doing the live monitoring, some of them like to shorten it to 1 or 2 hours. I still like a 4-hour for me to rapidly look at patients and see if there's major changes. And in general, for reviewing a study for the first time, like just an overnight study want to review, I usually will do a 1-hour trend to make sure I'm not missing anything. You won't miss much with a 1-hour trend, and you can still go through a 24-hour study very fast. So 1 hour for screening in detail, 4 hours is for my just rapid look at studies, somewhere in there, and then looking for things like alpha delta ratio changes over the whole day. We'll use a 24-hour window.
Excellent. I'm trying to see if
yeah, I can
some
look
general themes that we can talk about to fit into time. Has the quantitative EEG been used to change any protocol length or temperature, cool, rewarm periods to utilize in context of the EEG findings?
I don't think so. I don't, not that I know of. So, the other point about that is that seizures happen when you're cooled. And people used to think you just need to get the EEG on before you start rewarming. At least back when we were cooling to 33 degrees. And that wasn't true at all. A lot of the seizures started while you were fully cooled. So you want to get the EEG on as fast as you can. Yeah, you might see more as you rewarm, but definitely need it before that.
And we have another question about the cyclical patterns that you discussed. We see them during rest sleep, but also cyclical arousals happening at a metronomic time. How should we name these?
Yeah, well, CAPE is cyclic arousal. It's basically, they may not arouse to being awake in any clinically obvious way, but it is just cyclic arousal. Again, it's a variant of what happens normally in sleep. So yeah, that's CAPE. That very regular cyclic arousal is CAPE, and it's better to have that than to have a non-variable EEG. But there's like no literature on CAPE yet, but there will be soon. Now that it's defined, it was only defined fairly recently with the last ACNS terminology version.
Can you speak a little bit about why, or I guess this is, do you feel like a quantitative EEG is underused for ischemia monitoring? Or do you feel like it's something that people are starting to understand and use more? Or what are your thoughts on the utilization of it currently in the clinical monitoring environment?
Yeah, I think it's definitely underused. The why is mostly because it's a little bit of a pain in the butt to do. This way I kind of like the last version of the paper out of the Mass General group on just doing it qualitatively. We used to do it quantitatively and enter actual alpha delta values 10 times a day into a spreadsheet and look for statistical changes. But just looking at the tracing and eyeballing it is significantly easier. It's still a little bit of a pain, but when there's obvious changes, it's very obvious, and it works very well. I don't completely know why it's so underutilized. I also don't have any data on how many people are using it, but I don't think it's too widely used still, even though it's paper after paper after paper shows it's effective and it's better than transcranial Dopplers. There's some evidence that it's better to have both than either one alone, but if you had to pick one, EEG is clearly better than TCDs. But there's no reason to only pick one. So I don't really know. I think as people get used to it, as it gets a little easier, as these software packages get better and make it easier to set up, including the versus baseline, it's tricky to set up. And then there's the issue of dealing with noise and state changes and things is still a little bit complicated, but in the scheme of things we do, it's really fairly simple. So I'm not quite sure why it's not used more. Hopefully everybody on this will start using it more.
Yeah, I think we have a few different questions just about that in general, about how to introduce it to the clinics, how to start making sure there is more utilization, because it looks like you have a lot of evidence of it being an effective clinical tool. So I'll probably reach out to some of you individually who have more specific questions about setting this up in Persyst. I have another question about criteria on the alpha delta ratio to monitor vasospasm. Do you have a certain percentage of decrease or any type of criteria about that ratio that you feel would suggest a vasospasm?
Well, there are some general guidelines, but the bottom line is any change that you see that's persisting, a change from what you were seeing before, that's worth noting and is significant. The guideline that people use are based on the old study we did, the Klassen paper, that was a 10% change in that's consistent over many times, or a sudden 50% change once. But again, that's only just done by eyeballing the tracings now. So if you see a clear change, it's usually was what you see is a separation in the lines in the alpha delta ratio tracing. But it could just be there was a mild separation and now it's a wider separation. That's also something significant. So anytime you can appreciate a real change that's persisting, that's all you need. So you don't need numbers because you're visually looking at it. And that's what was nice about that last paper, is that you can just do it all by looking at the tracing. And then you do want to make sure you can confirm it. Sometimes you look and you think it's because there's consistently more muscle on one side than the other, and that will explain it all. But that's why you're a physician who still has to look at it and not just the computer.
We have a couple questions about seizure detection specifically. So can you tell us more about seizures as a predictor of brain damage starting to occur? I think you mentioned that as some epileptiform activity as some of the
Oh yeah, that it was
criteria.
Right. It turned out it was the new epileptiform findings, not necessarily seizures, but any epileptiform discharges or periodic discharge or any of those was the best single EEG marker of delayed cerebral ischemia. So it's not necessarily that the seizure or the discharge themselves are causing harm, but it's a marker of ischemia. And the ischemia is probably what's going to do more harm than the actual discharges or seizure. Having said that, we do know seizures can cause harm, but that's not what that data was about. It was about it being a marker of ischemia. So then you add ischemia plus seizures, and that's particularly bad. The ischemic brain can't handle seizures very well, not nearly as well as a healthy brain. So,
and do you ever have a trend specifying a specific channel if you know the seizures are coming from that region, like arising from that region?
Yeah, absolutely. You can do it on there's panels set up for single channel, or you can zoom into each region, or you can make your own. Yeah, we have done that where seizures are too subtle to see on the standard either hemispheric or region. And so we'll see that's clear in one channel and it's always in the theta band. You can make a a C3 P3 5 to 8 hertz power detector purely for that purpose, and then follow that. So yeah, you can set up all kinds of things on your own. I don't see too many people doing that regularly, but yeah, it's absolutely possible to do.
And then I think just a general question, do you have any advice or experience in overcoming objections to implementing this in a hospital setting? And there's a question about if you met resistance, expanding indications of continuous EEG in the ICU, how you practically overcame it, or how you would introduce this to a place that's underutilized, just along those lines.
Yeah, the best way is to give a little talk like the first half of this talk to your critical care colleagues. And then the other is that just have really good communication when you do it. So we try and make sure we round with the neuro ICU team every day. The best when they come as a team to stop by and we show them the EEGs and they tell us the story and we tell them what we're seeing. Does it correlate with anything going on clinically? And sometimes you'll see a diffuse change and they'll help you figure out what that is if they've changed their treatment or something. So diffuse changes can be tricky because sometimes it's multifocal vasospasm or DCI, but more commonly it's because they increase their drip of some sedative. And you can figure that out. When it's a focal change, it's much easier to know it's something to be worried about. So communication is key, and yeah, some education, and there's certainly plenty of literature out there on showing the utility. The other thing is to pick these things up reasonably fast. They don't want to hear 24 hours ago there was a major change on the EEG. So I'm not saying you need to look at it continuously or give them hourly updates. That's ideal, of course, to look at it continuously, and there are some places doing that. But at least look at it, several times a day. It's fine to say, look, there's some change seemed to happen, 4 hours ago, and it's persisting. But it's not too helpful to tell them it happened 24 hours ago, or don't tell them on Monday that it happened on Friday night.
We have another question about anesthetic agents. Are there any medications to be avoided? And this person mentions Ativan.
No, not really. I mean, some will have more of an EEG change or hide seizures or spikes, but I never thought about that. If you put them on something like Ativan, they might be less likely to have spikes, and you might miss your window of detecting DCI earlier. But haven't worried about that much, because we still see plenty of people with seizures and periodic discharges and spikes who are on all kinds of these things, including midazolam and propofol. So the drugs aren't that good. I don't think they're going to prevent you from seeing the early signs of DCI, but that's an interesting question. I don't think anybody's looked at that.
And then the last question will be this one about using heart rate trend for assisting seizure detection. Is that something that you utilize?
We have not, but we probably should be. Yeah, it certainly can help, and is in the outpatient world for seizure detection. I think that's of huge importance when you don't have the EEG at the same time. But no, we really haven't done that, but I think others are, and I can't say too much about that.
Okay, excellent.
But
Well,
I do see one question: is alpha delta ratio calculated manually? No, the Persyst does it for you, shows you the tracing and gives you the numbers. Let me see, any other I can quickly. Do we use any graph representations? We take snapshots of the alpha delta ratio tracings and put them in our report every 24 hours, and our reports will have the last several days at least of the ADRs for the subarachnoid hemorrhage patients. Talked about that one. Technologists are great for keeping an eye and telling you when there might be a major change, so they can look at it much more frequently over the day. So having whoever's watching your monitors alert you that there might be a change is great. That one takes too long to answer. How do you group electrodes? There's pretty standard ones, and the Persyst folks can tell you about. Do you recommend any book to read? Well, if you want lots of examples, there's an atlas that I think I referenced about 30 times during this. Yeah, our atlas is very good. The handbook of ICU-EEG monitor. There's any book basically or atlas on ICU-EEG will have lots of examples, and the Persyst website has all kinds of stuff, and they'll also give you training if you want. All right, I think that should do it.
great. Well, we all really appreciate your time today, and the examples that you shared were incredibly helpful in understanding, especially other than seizure detection, applications of quantitative EEG. For those questions we didn't get to, we will be reaching out as Persyst to help you with especially the more technical questions about how to configure some of these different panels and trends. So we'll be following up with you shortly after the talk. But this will be posted on our website for you to review later as well. Thank you all so much for joining today, especially to Dr. Hirsch. Thank you again for sharing this talk with us today.
Thank you. Thanks, everybody. Thank you, everyone, for joining.
Thank you. All right.
Bye-bye.
Bye-bye.